Okay, all right. Good afternoon, everyone. Good afternoon, colleagues, IPC practitioners. It's my pleasure to welcome you all to today's special section. We know, as we all are aware, we're commemorating the World Hepatitis Day with the global theme, hepatitis. Let's break it down. Each year on July 28th, we are reminded that this viral hepatitis remains one of the world's deadliest and yet most preventable diseases. So despite the availability of effective tools for preventing, testing, and treatment, millions continue to be affected, most of them unknowingly. So today we're going to look at a topic. We also have our speaker who is going to, go into today's topic. We're looking at hepatitis prevent, protect, and vaccinate. I'm going to introduce our speaker, Dr. Data Idowu. He's a gastroenterologist and also a hepatologist with the Federal Medical Center, Ebute Metta, Lagos. So let's do welcome our speaker today, Dr. Dada. Dr. Dada, you have the floor. Let's welcome him with our emojis in the chat box. Welcome, sir. I'm going to project your slide now. Thank you. We're really excited to have you here today. Thank you for the time and also wanting to share your expertise with us. Please confirm that you're able to see the slide, everyone. Are you able to see the slide?
Yes, we can see the slide.
Oh, that's great.
Yes, we can.
Yeah, we can see the slide.
That's great. Thank you so much. So, Dr. Dada, you have the floor now. Welcome, sir. Please, are you still on the call? Please be sure that you're not muted, please. Dr. Dada Idowu, okay, he's on the call. Please be sure that you're not muted. We can't hear you from here.
Hello, moderator. I think you can unmute him. Try.
Okay.
I think you can unmute him.
Yeah, that's what I'm trying to do. Thank you, ma.
Can you hear me now?
Yes, we can.
Oh, sorry.
Yes, we can hear you.
Okay, ma.
Jesus.
No
Yes,
problem.
we can hear you, sir.
Go ahead.
Okay. So, sorry. As I said, I'm presenting the topic of today, which is welcome everyone. My name is already been mentioned, and this is the topic I'm presenting today. This is prevention, protect, and vaccinate using the strength of IPC to fight hepatitis. I will be going through my outline, which is talking about the brief overview of the viral hepatitis itself, then followed by a brief overview of the hepatitis B infection, then overview of hepatitis C infection, then IPC component for preventing hepatitis B Also, I will talk about pre-exposure prophylaxis for hepatitis B and post-exposure prophylaxis for hepatitis B before I round up in conclusion. So my first is to talk about the brief overview of the hepatitis itself, and that is by talking about what hepatitis. The hepatitis. Hello, can you hear me?
Yes, I'll go ahead. We can.
Okay. Okay. Hepatitis. Sorry. What's wrong? What's happening? Do you have a network here? Oh, this thing. Hello, can you hear me?
Yes, we can hear you. I'm also projecting your slide from here.
Okay, because I didn't see any slide.
Okay.
That's why.
Possibly it's network.
Okay, I'm coming.
Okay, sir.
Okay. So, brief overview of the viral hepatitis. Viral hepatitis refers to inflammation of liver caused by hepatotropic viruses. And we have about 5 types of them. We have the hepatitis A, hepatitis B, C, and D. Then we have E and D and E. So the viral hepatitis A, B, viral hepatitis B and C are more specific for liver with D, while they can lead to chronic kidney disease, while A, E causes liver disease, but they are usually acute in nature. The viral hepatitis is a global health concern because of the potential for causing chronic liver disease, cirrhosis, and liver cancer. Each type has different transmission routes, symptoms, and treatment options. For example, the transmission of this virus will have different routes. Like, for example, A and E are usually fecal-oral, that is from contaminated food or water, while B and C are usually from blood and body fluid, which could be example from sexual contact, or it could be from perinatal. D, hepatitis D could be a co-infection or a super infection. But however, it's really co-infection with hepatitis B viral infection. Viral hepatitis is often asymptomatic in most cases. In fact, most of the time, patient comes with complications. The common symptoms that they normally come is usually jaundice, fatigue, loss of appetite, nausea, and abdominal pain. And treatment varies according to each of the viruses that are affected. For example, hepatitis A and E are usually self-limiting. They respond very well with supportive care. While B and C and D, they are usually respond with antiviral medication. The prevention of viral hepatitis include vaccination, which is usually available for A and B. Then safe practice, which include hand hygiene, safe sex, avoid needle sharing, safe needle handling, and screening of blood and blood products. The diagram shows what I just explained, how it can be prevented from hepatitis B, A, B, C, D. Proper hand washing, gloving, proper disposal of waste, and also know how having a safe sex. Then we go to the overview of the viral hepatitis B. Hepatitis B is a double-stranded DNA virus from which it comes from a family of virus, and it affects liver mainly, causing inflammation and leading to severe liver damage. Incubation period is usually 1 to 4 months, an average of 75 days, and transmission could be through parenteral, which could be IV drug use, blood transfusion. It could also be from sex, sexual, which is unprotected sex, and it could be from mother to child, to mother vertical, which is mother to child at birth. Other sources that we now commonly is tattooing, piercing with unsterilized tools. Symptoms also range, as I said, from mild to moderate, but most of the time, most of our patients comes with complications like ascites and all, but detecting early like jaundice, fatigue, loss of appetite, and abdominal pain. Here is the diagram that connotes what I just said: the fever, the loss of appetite, and jaundice. The hepatitis B could be acute or chronic. Acute hepatitis B infection is short time, and the one that can easily lead to acute liver failure, which is characterized by coagulopathy, encephalopathy, and the loss of consciousness, which is encephalopathy. Then, while the chronic one is defined when there is a persistent of hepatitis B surface antigen greater than 6 months, and this can lead to liver damage like cirrhosis, hepatocellular cancer, hepatocellular syndrome, or liver cancer. Prevention could be through vaccines, which is highly effective, and screening of blood products, use of barrier protection in sexual activity, and so on. Treatment also depends on clinical phase of the infection. We have about four phases. I believe it's not, I will have put, but I just believe that on a different gathering, I will have put that. But since we are talking of IPC, that's why I think, but there are about 4 phases, clinical phases of hepatitis B, and each phases depend on how you can be able to treat your patient. Mostly we use antiviral agents like tenofovir, entecavir, and pegylated interferon. These antiviral agents are classified as first line management, second line, and third line. And the pegylated interferon, they are the one that we use if you prefer injectable. Then hepatitis B infection is one of the global health concerns with high prevalence in certain regions. So therefore, early diagnosis, treatment, and prevention through vaccination and crucial management of HB infection and increase the complication. Most of the regions that are affected most, if you look at the picture I changed, usually the Asian, the African, the Asian, very well, those underdeveloped or moderately developed area, because number one, knowledge of vaccines, number two, poor hygiene, and number three, poor sexual exposure in our environment probably leads to that. That is why most of the time we see a young, less than 20 or 25 years, having a cancer because of lack of knowledge of vaccination and other things in our environment. We go to the next step, which is overview of hepatitis C. Hepatitis C is a single-stranded RNA virus belonging to flaviviral family. It also causes liver inflammation, sometimes leading to severe liver damage. These are just the diagram outlining the structural component of hepatitis C. The envelope, the capsid, the RNA virus, and this thing. We don't need to go deep to that. Then also the incubation period is usually 2 to 6 weeks, an average of 6 to 9 weeks. Transmission of hepatitis C is primarily blood-borne, transmitted through the IV drug use, blood transfusion in the era of our early 80s. Although it's not too common now, but in early 80s, the blood-borne blood transfusion is usually the high content. The commonest site that has that epidemic of endemicity of hepatitis C then during the early 80s in Egypt, when they're having this tattooing culture. So sharing of needles or contaminated medical equipment is also very important because it can transmit the disease. The route of vertical transmission is a subject, but from the medical aspect of that, gastroenterology aspect of it, it is speculated that 1 to 2% of vertical transmission can also be due to hepatitis C. The sexual transmission is also about less than 1% of the disease, but the greater number of transmission of hepatitis C is usually blood contact, blood contact, maybe IV drug use or blood transfusion. Then symptoms may also include just like hepatitis B, fatigue, jaundice, abdominal pain, and sometimes patient may become asymptomatic. Hepatitis B can also come in form of acute and chronic, just the way I described the disease. But the difference here is that the asymptomatic chronic hepatitis B occur in most cases of 70 to 85%, while chronic hepatitis C remain asymptomatic for years and may also lead to liver disease without the patient can just form. Then when you see the patient develop fibrosis and cirrhosis and cancer, but it takes time for hepatitis C to develop that. Hepatitis B sometimes could be an oncogenic, that is, it goes from infection straight down to cancer. We call it the hepatitis B in vivo. That is, it goes directly, it's an oncogenic that contact the patient today. In the next maybe 2-3 months, the patient develop a cancer. In hepatitis C, it's not like that. It goes through the phase, and it takes years to develop that cancer. So it has about its own phase, and it has to go through that phase to develop that stage of cancer. The treatment also, we use direct anti-acting antiviral agent, such as sofosbuvir, glyphosate. Those are the recent one that we use in pan-genomic. In the olden days, we use genotype to identify the type of drug that we use to treat hepatitis C. But in the era of modern technology now, drugs have been produced in form of pan-genotypic form that you can take all the types of hepatitis B and manage them together. So we use, most of the time now, we use pan-genotypic regimen. The prevention usually, as I said, is safe injection practice, screening of blood product, safe sex, and reduce harmful strategy. The hepatitis cancer is a great global health concern with millions affected worldwide. It can be asymptomatic for many years, as I said, making screening very crucial. Early diagnosis and treatment can significantly improve outcome and prevent long-term liver damages. Now, we talk about the IPC, that is infection prevention and control component for preventing hepatitis. Hepatitis generally, which is our basic concern in the presentation. We have many components of IPC, which all of us should be able to know, and what we should be pushing as part of our even doing for our hospital community and even our community where we are living with. Hand hygiene, a regular hand washing with either soap or using alcohol-based sanitizer is very, very important. It's a standard precaution that health worker and even people outside, people outside who you should be able to know how to learn. Whatever thing you do, wash your hand. Personal protective agent, equipment, wearing of glove, mask, eye protection, when antibody fluid for we, the health workers, and also when we are exposed to patients' body fluid, other things. These are things that we should always have as a basic step in mind. Safe injection practice using sterile needles and syringes for, in fact, the slogan is one needle, one syringe, and it should be disposed immediately into a safe box. These are just the diagrammatic of what I listed up: the hand glove, the face mask, the goggle, the eye goggle. All these things are personal protective equipment that has to be available in every of our organization. Even some of them at home that we can use to attend to any of our patients. Sterilization and disinfection is also very important to sterilize our equipment and also the surface where we want to use for the procedure we want to do. Vaccination. All health workers are encouraged to vaccinate against hepatitis B, which is also a very important part of the hepatitis infection. The standard precaution, like following the guideline by handling body fluid, just like what you just mentioned, it should be part and parcel of us. In fact, it should be our daily life, all this procedure, precaution, so that whatever you want to do, nobody should tell you. You should be able to tell people that are not aware. This is just the diagrammatic expression of what I earlier expressed. The education and training, the repeated education and training is also very important for workers in IPC practices and hepatitis prevention. New staff is being employed. IPC has to come in for training, and even the old ones, they need to be retrained so that this will be part of the activities that should be maintained in the hospital. Then surveillance and monitoring. These are a group of people that are assigned to monitor what did any good deed or any bad to correct what the institution that have been there to monitor and to correct and to add to it. Then the other two last component that I wanted people to learn about is the pre-exposure prophylaxis for hepatitis B and post-exposure prophylaxis for hepatitis B. Pre-exposure prophylaxis for hepatitis B is a prophylaxis against hepatitis B for before potential exposure to the infection. And this is recommended for high-risk group like health workers, injection drug user, men who have sex with men, an individual with multiple sexual partner, and a dialysis patient. Infants and children, routine vaccination is recommended for all of them, since it is also part of the Nigerian MPC program. Then travelers moving from one area of endemic of hepatitis B, one area of low endemic to area of high endemic prevalence of hepatitis B. They need this pre-exposure prophylaxis because it's highly effective and it prevents infection from being potentially exposed to hepatitis B. The pre-exposure prophylaxis for hepatitis involves the administration of the hepatitis B vaccines. We have about 3 doses. In our MPI program, we have the advance, then at 1 month, that is 4 weeks, then the last one at 6 months. It is also good for us as a booster, especially the health workers who are exposed to all this body food most of the time. It is encouraged for us to have the pre-exposure prophylactics of the vaccine 3 times in that 3 times that 1 year is very important. It's highly effective and it's likely to be a lifelong in the body. Here we do have in the FMC, we have the one we give to staff, everybody. I think nowadays it's not available, so we have to ask the staff to buy it. I think it's selling in a pharmacy around 13,000 naira per vial. So it's encouraged that we, the health workers, we should be able to have, because some of the health workers are exposed to it and they have to come in for post-exposure prophylaxis, which is also very highly effective. However, if the patient has been having a pre-exposure, there won't be anything fear to have any alarm. Then this is just the diagrammatic and the table showing the vaccines, the duration of how it's going to be taken. In our MPI is usually at about 1 month, then at 6 months, which is also assigned to anybody that want to take the vaccines. Then the benefit of this pre-exposure prophylaxis include highly efficacy. The vaccine provides long-term protection against hepatitis B, and it also prevents chronic diseases. The vaccination prevents chronic hepatitis B infection, which can lead to cirrhosis and cancer. Then it also is safe and well tolerated. You can, as a health worker, just buy it, give it to your colleagues to give it to you, and that is all. No side. The minimal side is just being at the site, or you may have some little local malsitis at that region. No really anaphylactic reaction. In as much as you've tested that you are negative before you take the vaccines. So post-exposure prophylaxis is post-exposure for hepatitis B is to prevent hepatitis B infection after exposure to potentially infected blood or body fluid. This involves the administration of hepatitis B immunoglobulin immediately or passive or short-term protection. Yes, once a patient or once health worker is exposed to already known patient of hepatitis B, it is advisable that the patient can quickly have to alert our unit for post-exposure dose of immunoglobulin. It's also useful for infants with a positive order who is about to deliver. Once the infant is delivered, it's also very useful to give the post-exposure to the deliver. What are the indication for post-exposure? It is recommended for unvaccinated individual exposed to hepatitis B through body fluid, needle stick, or sexual contact. Incompletely vaccinated individual, those with known, unknown, or incomplete vaccination. This word connotes patients who are not aware that they complete their immunization status. Then also a partner of a positive wife or husband is also very important. The patient who is a transplant patient is also very important. These are people like a transplant patient, especially liver transplant patient, who had a liver transplant because it's hepatitis B. We need a post-exposure prophylaxis for the new transplant liver that he just got, so that he will not have a repeat hepatitis. Then the newborn baby, as I already said, positive mother. Hepatitis B immunoglobulin is used to provide the shot, as I said, and as I said, a bat to prevent mother to child transmission of newborn baby to mother, just like what is usually given within 72 hours. You understand? Not 24 hours. You can be given even up to 7 days in some cases. It's all just advised that once mother, before the delivery, you should just buy it down. Maybe buy it down, keep it in the fridge. The moment the baby is born, you give the baby just, and once you are exposed to it, you have the grace of 7 days. But it's advisable that it should be taken within 72 hours. The administration is usually intramuscular. Never give post-exposure prophylaxis through IV because of the anaphylactic reaction that it comes with, like angioneuroma, angioedema, angioneurotic edema, and it can also causes thromboembolism, which is very important. So thromboembolism, you should not give through the IV. Usually given through by the deltoid muscle in the arm or the thigh, the lateral side of the thigh. Those are the place where you can give the hepatitis B immunoglobulin. The benefit of it, as I said, is immediate protection and prevention of when giving it helps to prevent hepatitis B. There's nothing like another thing. It's very effective, and studies have shown that many people who has it are happy to announce that they didn't get the hepatitis. This is the dose of the post-exposure hepatitis B immunoglobulin, usually given 0.06 ml per kg. So if you know your weight, just calculate, use your 0.06 ml per kg. Then you just give that dose, and that is all. This is the dose, 0.06 ml per kg. Start. That is all. So in conclusion, I prevent, protect, and vaccinate capture the core of hepatitis control. Robust infection prevention and control practice plus universal hepatitis B vaccination, both that's batch dose of full series and targeted immunization of high-risk group. When health system pairs this with screening, linkage of care, linkage to care and post-exposure prophylaxis, the cut transmission to hospital, in the hospital and community, protecting healthcare worker and patient, and drive chronic liver disease and drive down chronic liver disease and hepatocellular cancer. Investing in IPC infrastructure, continuous staff training, and vaccine access is cost-effective, scalable, and life-saving. In short, stop transmission at every interface, shield the vulnerable, and close immunity gap. Thank you very much.
Thank you so much. Thank you so much, sir. We really, really appreciate. Thank you. Please, let's appreciate our speaker using the emojis in the chat box. Thank you so much, sir. We really appreciate the time that you have shared with us, especially your knowledge, expertise with us. Thank you very much. I'm looking out for questions in the chat box. Please, if you have questions, contributions, comments, it's a really very, very important topic, very timely, not just because it's at the annual World Hepatitis Day, but it's something that, you know, we need to reflect as healthcare workers. Okay, I can see a hand up. Okay, please go ahead. You have the floor. You have a question. Please go ahead. Question or contribution. Okay, Dr. Lawal, please go ahead. You have the floor now. Thank you.
Okay, good afternoon.
Good afternoon, sir.
Good afternoon, sir.
Dr. Dada, thank you very much for this elaborate lecture, which is apt. I have two questions. I have two questions to ask. One is concerning the immunoglobulin for hepatitis B. How available is it in the country? That is one. The availability of the immunoglobulin for the hepatitis B, sorry. And then my second question also is still on the immunoglobulin for the hepatitis B. I want to understand, at what level of exposure do you give the immunoglobulin? I mean, if for instance, does it has a golden hours that maybe after that, even if the person that is exposed is given, it will not confer any protection? Thank you so much.
Okay. Thank you very much. Should I go ahead, or I should write all the...
No, please, sir, go ahead. We'll take it one at a time. So go ahead.
Okay.
Yes.
Okay, yes. Availability of immunoglobulin in Nigeria is nothing to write about. In our environment here, where I am in Lagos, we have some specific bigger pharmacy that do sell the product, and they are very expensive. They are very expensive, up to almost 250,000, 200 to 250,000 naira. So, and they are even not about the availability is also, somebody has to go all the way to Island or even Ikeja, and even then they will tell them to come back, that they have to order for it. So we have a challenge in making these drugs, or maybe this vaccine, very, very available for our needs, for the populace. Yes, we have a challenge about it. So it's not readily available, and when it's available, it's also very expensive. So accessibility is also very impaired. So we have problem about availability. For the dose cage, as I said, there are two studies that was conducted for a dose of hepatitis B immunoglobulin given at 72 hours and dose given at 7 days. The 72 hours happen to have a longer protection. I mean, a kind of susceptibility in 72 hours is so high, of about roughly 98 to 100%. While for that 7 days, it's about 95 to 97%. So it still said that you can give up to 7 days, but it is advisable to be given within 72 hours. And as I said, the dose is 0.06 ml per kg. Thank you.
Oh, thank you so much, Dr. Dada. That question is very, very important, especially looking at the theme for the World Hepatitis Day. Let's break it down. The barriers to elimination of hepatitis, and one of them is accessibility. And now you can confirm that, do not even have enough vaccines to protect healthcare workers. During your presentation, I heard when you said that because it's not available, a healthcare worker has to go and buy. That's not really a very wonderful thing to hear. So what can we do differently now? Looking at solutions, what can we do as IPC practitioners? What can we do differently, to ensure that these things, don't keep happening? We're looking at the barriers. How can we break these barriers?
Yes, ma'am. In this, for the solution for something, what I believe the solution would be, we should raise an advocacy at the primary, tertiary, secondary, and tertiary level. For example, in the primary, we should let our community to know that there is this something like this that you can use to protect yourself. At the secondary level, which is for us now working in secondary general hospital, also it is important to involve the state coordinators or state Ministry of Health that this is what these people need. Once they are aware that their existing is useful for their protection, why can't we provide something like this for these our people and make it accessible and affordable for our people to be used? Then at the tertiary level, which is the government now, you should find a way of subsidizing the rate and also make it available for the down thrower, that's for us to be, and also accessible. I think that's just so it involves a high stake level of IPC coordinators to come together, fight for the need of the people and to reduce the surge of hepatitis, because it's very alarming. We have so many that end up dying. We can't do, but once they develop the cancer, the money for the cancer drug is even very expensive. Each one for immunotherapy itself is about 3.7 million in 3 weeks, and they are going to take it for life after some, So those are things that we are trying to avoid. So we need to make this thing available. The vaccines itself, the vaccine here is 13,000 naira. That's what we sell it in our pharmacy here. Wow. So outside, I don't know how much they sell it, but I think it's subsidized when they come to the hospital. So it's 13,000 naira. So I have a staff that just bought it 13,000 for 3 doses. 3 first dose, 13,000, 3, that's about 39,000 naira. Wow. So talking about the staff that went to buy, that the hospital has to return the money, bought the immunoglobulin 250,000 naira. So it's something that we need to, our coordinators need to come down to the government and say, okay, see the bonding of hepatitis B, just like what we did for HIV. We can do it because people are dying of the hepatitis B more than the HIV, honestly. They have so many in the world now that die. So we can prevent it because they have a partner which can benefit from the immunoglobulin, also the vaccines. They have to take the two together, and it has prevented them for life. So I think we need to work on that primary, secondary, and tertiary advocacy to make it available, accessible, and affordable to our people. Thank you.
Thank you so much. Obviously, we hope that this advocacy, translates into actions. Interesting. So, okay, before I go through the chats, I would love to give the floor to people who have raised their hands. Okay, Dr. Joseph Fidika, please, you have the floor. Go ahead with your question or comments. Thank you.
All right. Good afternoon, ma. Good afternoon for the presentation.
Good afternoon, sir. Yes, sir.
I wanted to ask, what? Thank you, sir. I wanted to ask, what is the position of someone that took only and didn't come back after like 10 years or so? So the person is reporting that
Oh, we can hardly
This
hear
is,
you.
we can't hear you. It's breaking.
You may have
Your
to
question is
type.
breaking.
You may have to type the question in the chat box. We can hardly hear you, sir, but I think a little bit of what I heard is for people who did not continue. Like, I think the person
of the
Yes.
vaccine.
Yes.
Again, or is he? Am I audible now?
Okay, yes,
Yes.
go ahead.
We can hear you now. Yes.
Oh, I'm not sure he's still.
Hello. We lost you.
Yes.
We can't hear you.
Okay, please, sir. Okay, we hope that he has to, type the question. Okay, so can we have Dr. Simple? You have the floor. Please, let's have your question or comment or contribution. Thank you, sir. Dr. Simple, go ahead.
Hello, am I audible now?
Yes, you are.
Yes.
Go ahead.
We can hear you, sir.
Okay. Good evening. Well done, Dr. Dada, for the elaborate lecture.
Yes, sir.
I think in
Yes, sir.
terms of advocacy, today, one of the commentary on Radio Nigeria is about hepatitis B, and that the federal government has declared intention to eradicate hepatitis B by 2030. But I think it comes down to advocacy, as you have said. Now, some states are actually making effort to provide free and accessible vaccine for hepatitis B. I know here in Abuja, any primary healthcare you go, you get the vaccine free. All that you need to do is just to pay for the screening to be sure you are negative and you commence the vaccine. The same thing in Yobe State. In fact, you can go to primary healthcare in Yobe and even ask for the vaccine. They can even give you the vial if you are far away. So at the level of state, because there is a lot of money being pumped into primary healthcare now from the health act that was signed, I think 20 or 2022. So it's at our level. But my worrisome concern is even at the healthcare level, you will see that all healthcare workers that are attending to this patient, ask them about the hepatitis B vaccine. You will be shocked that none of them, very few, have collected the vaccine. So I think most of us that are leaders in the healthcare sector need to make it like a official, is it document or law now that anybody that is being employed into any healthcare to work must know his hepatitis B vaccine status. If they have not been vaccinated, then the management have the onus to go and make sure that they are vaccinated before they start work. So I think that's the most visible part, because I talk with house officers. To my surprise, all of them, very few. And if you tell them what is the reason, no tangible reason why people are not vaccinated. So that is it. Now, with regard to immunoglobulins availability, it also depends on the state, because I knew some state, the antenatal clinic, where most of these pregnant women came anticipating babies and all that. I think most of the clinics, they have the list of accessible pharmacies where, in fact, they can actually ship the vaccines to them, especially in Yobe and some states. So it would be good if we can, through working with antenatal clinics, I think that's most of them where those immunoglobulins are being requested very frequently. So anybody that is in need of it can contact anywhere antenatal clinics are operated in tertiary institutions. Most of them have access to those immunoglobulins. So thank you very much, sir, and we hope that this lecture from us here, a lot needs to be done. I know of a village in one of the states that if 20 people comes to donate blood, it's likely 18 or 19 hepatitis B positive. In fact, that community can even ask them for blood donation. So it's actually a very big burden on us. In fact, they say every hour about 9 people died of hepatitis B and C more than malaria and HIV. So it's actually a big challenge and a problem for us. So we need to work on that. Thank you very much. I think that's my comment.
Okay.
That I have to say. Thank you, sir.
Hold on, sir.
Thank you,
Somebody
sir.
is asking which part of Abuja is this vaccine available? Is this something that?
Well, I just got booster box for my children and my siblings. If you go to primary healthcare in Nyanya, in
Okay.
Njikwe, Yes, wherever primary
That's
health
very
care is
good.
in Abuja, except otherwise they're available.
Yeah.
Because
This
if you
is
come
not
to one, if there's not available, they will refer to another one. Yes.
okay. Hope this is not
I have some
exclusive to Abuja.
from my kids' school. I think about 10 of them. When I gave them some brief lectures, most of them came and they were able to get the vaccine. If it's not there, they will request it immediately from other facilities, and they will give them free. All they need is 2,000 to screen to be sure that they are not hepatitis B. So it's
That
been
is
very
very
effective there.
interesting.
Yes,
Interesting.
sir.
That's very interesting. Thank you very much, sir. Thank
Could
you,
it
sir.
be
You're
because
welcome.
they are closer to Aso Rock? Because I don't know.
No, not because of ASROC. You know, where the seat of government are people, where people are being supervised to do their work. People will sit up. Know that
Okay,
these vaccines are not being provided.
yes, sir. I think
But if
I
somebody
reason with
comes
you.
there,
Yeah.
yes, if people come there and it's not there, people will make noise and shout, and people will hear it at the higher level. So that is it.
Okay.
Yes.
Wow.
Thank you very much.
All right.
Thank you, sir.
You're
That's
welcome.
good.
Okay.
That's
Thank
good.
you so much. Thank you so much, Dr. Simple. I think maybe some of us need to start asking questions, to be sure. Yes, because it could be that, provisions have been made, but, somebody is not doing the right thing. So we need to. Okay, so quickly, I can see a hand up. Kufre and them, you have the floor. Please go ahead with your question, Dr. Kufre. Dr. Kufre, go ahead. Thank you.
Thank you. Good afternoon, everyone. It
Good
has been a
afternoon.
wonderful time. I think I learned a lot. Okay, before I ask my question, I just want to also ask the last person that just talked about getting it free, because I know in primary healthcare centers, you pay money for it, so it's not free.
Which state?
Even here in Lagos, you pay.
Abuja, I'm in Abuja.
No,
In Abuja.
that's what I'm saying.
Yes,
Hello,
even
what
in
I'm
my
saying
own
is that
hospital.
yes, you need to ask. I went to choose in your care is completely free. Here in Abuja, I told you, I vaccinated, in fact, booster dose for my children, his class, and all that was asked is 2,000 naira to screen for hepatitis. Yes, it's free. You can come here to here in Karo or primary health care, Jukwe, Nyanya, all of them are that. I'm very sure of that because I did it. Not that I'm saying it. So it depends on the center, and because most of those vaccines are provided by the federal government, it's actually free. If primary healthcare vaccines are free, they are not to be sold, except in private hospitals. They are free. Just like they are part of the MPI program. They are free.
Yes,
Thank you very
what
much.
Dr. Simple is saying is
I
true.
will
In
now,
Adamawa,
I think
it's also free.
I can
In
refer
fact, even
patients
this morning we get someone.
I can now refer patients to take it.
We still have free in Adamawa. I can confirm that. All the PSC, they have it. And even the test is free in PSC.
Okay, thank you for that information. I think I will start referring patients to for the vaccine. But I know this more about IPC and prevention. I just want to ask, please. We know tenofovir is the antivirus, the drug of choice for management of hepatitis B. But combinations that have both tenofovir and lamivudine, or maybe with other antiviral like maybe dolutegravir added, are they suitable for management of hepatitis B? That's my
Okay. Okay, thank you very much. You need a single antiviral agent for care of hepatitis B. The targeted combination therapy that you just mentioned now, they are used to attack HIV because HIV has targeted pathogenesis. So that is why it is combined. But for hepatitis B, it's a unidirectional pathogenesis. So that is why it's only for you to use the only one of them. Either you use tenofovir, depospivir fumarate, or tenofovir alafenamide, or you use lamivudine. Lamivudine used to be the line before, but because of the issue of resistance that it has, and also the efficacy is not as that of tenofovir. Tenofovir has almost about 20% efficacy, while lamivudine is about 78 to 80%. So you still have that 20% of having resistance for the virus. That is why tenofovir, in fact, most of the time now, you use tenofovir alafenamide because it is renal friendly. It cannot cause Fanconi syndrome that tenofovir deposit fumarate that can cause in a long time. So we use tenofovir alefenamide, which once you take it that very day, you piss it out and you take another one the next day. So that's just, so it's a single antiviral agent that we use now for the cure of hepatitis B.
Okay, Kai, thank you very much. I'm very grateful.
Thank you.
So let me add something here. Most of the times where you see people are using combination of lamivudine and tenofovir, they are trying to use free drugs from HIV program, and you have to discourage that. Yes, instead of them, especially those in NHIS program, if they go to the pharmacy, if you prescribe, they're likely going to give them that combination. So I insist that they should give them tenofovir along, not with lamivudine. So if you see that combination, it's from HIV program that people smuggle that drug and they want to use it for that purpose and collect money. So you should ask questions, please.
Thank you so much. Thank you for that insightful response. We really appreciate that. Okay, Dr. Kennedy's hand was up, but I don't know if he's still on the call. Dr. Kennedy, can we have your question while I go through the... yeah, go ahead. You're muted, please. Please unmute. Okay, I don't know if he's still here. I'm looking at the comments, the chat box. So someone has asked, can patients with cancer take the vaccine for hepatitis B? Dr. Dada, someone is asking, can patients with cancer...
Yes. I mentioned that indication for hepatitis B immunoglobulin is specifically for a patient with transplant. And you know, when I mention transplant, I mean all the immunocompromised patients, because they are prone to develop reactivation of hepatitis B. They may have ab initio on that is not active because of their immunity. Because of their immunity. So once the immunity is down by cancer, by transplant, by any of the immunosuppression, the activation of that hepatitis will come up. So you need that vaccine.
Okay.
Especially the immunoglobulin. Yes.
Okay, thank you for that response, sir. Okay, so now Scalifat is asking...
Okay, Kennedy's here.
Okay, you're here.
We give A.
Yes.
We give
I'm
A
sorry,
too.
I think I'm... Hello, ma'am.
Okay.
Hello, we can hear you.
We can hear you.
Okay. All right, good afternoon. Sorry, I think I'm actually having a network issue. But if you can hear me...
We can.
All right. I think my question basically is still revolving on this vaccine. Yes, the adult vaccine, it's quite scarce and even expensive whenever it's available. But I have seen instances, especially at the primary health care center, the pediatric hepatitis B, are being given to adults. So I want to find out if that pediatric actually works for, adults. And the second part of that question would be that I think during the presentation, I think the schedule, you mentioned the third dose be taken at 6 months or thereabout. But in some instances, especially in these primary health centers, they give 1 month interval, making it within a space of time you have completed the 3 doses. So please, I want you to speak on that and enlighten us the more. If all these are these scenarios are really advised. Thank you, sir.
Okay. Thank you very much. In terms of pediatric dose for vaccines and the adult dose, I think it's better to look for adult dose. Adult dose is what we notice that it's very scarce. Pediatric dose, yes. The reason why it is mentioned pediatrics and adults is because of the strength of the vaccine, the strength. So, adult, it's just like normal drug we are taking. You can see that pediatric is really strengthless compared to our own. So that was the reason. So taking pediatric dose, there is no study to compare So I cannot talk about the comparison because I was unable to get a study to compare our efficacy pediatric dose to adult. But I think it's advisable that we should just go for the adult vaccines and the pediatric vaccine for pediatrics.
Yeah, thank you, sir. Why am I highlighting this? Sorry, sir. Why I'm highlighting this is that for those people who said that they are getting it from this, getting it free from this health center. So, yes. So, which one are they getting? Which one are they getting? So, I want us to clarify that, sir.
Okay. I think maybe Dr. will be able to tell us because
is Dr. Sepu, hello?
Hello? Okay, yes, sir.
If you go to the primary health care, if you're an adult, you are asking for that vaccine. What do? They will measure your weight. The dose they are going to give you is not the same thing with the pediatric dose. And it comes in a single vial. They know their work there, and you ask questions. Yes.
Thank you.
They measure your weight. Based on your weight, they will give you your adult dose. It's not pediatric dose they will
Thank
give
you very much. Because
okay.
Hello?
No, sorry, what is he saying that the pediatric formulation can be given to adult based on adult dose? Is that the clarification is trying to make?
Yes.
What I'm trying to hello, listen. Yes, the hepatitis B vaccine is vaccine. The one that is incorporated in children is based on their weight. That's why they give to neonates at birth, and regardless of the age of the child, they measure your weight even as adult. It comes in a different vial. If your primary health care is actually knowing what they're doing, if you come as an adult, they will measure your weight. The dose they will give is different from that of a child.
Okay.
Me, my hepatitis B vaccine that I collected is from the primary health care center that I went, and I collected. The man showed me the vial, and I asked him, is it the same thing, the one you're giving for children? He said no. Even if this one, I measure your weight, and then I'll give you your dose. So they know their work, not that they will give you children dose.
No, sir, for us here, is I think we just want to put the record straight so that we will know better. Now, what I know concerning the pediatric hepatitis, which is the one that is readily available and it is free, it's even free. There is no way you are going for adult formulation that you get it free anywhere. I have never seen that. But what I can say here is that I want us to clarify is that how efficacious is that pediatric dose when it is administered to adults.
Don't make that statement. I have vaccinated all my staff in an IPC program.
Fact, that's what I'm saying.
Primary health care
formulation, it's not provided free. I have never seen that. That's what I'm saying.
What I'm telling you is depending on your state. Depending on your state, where are you practicing?
Hold on, sir.
No, I'm telling you what I've done. You're arguing from what I have done and I've taken. That's why I'm telling you that you're saying is not correct. It's never provided free. It's not true. Then they provide meningitis free.
They are two different things, sir.
Adult,
but what I'm trying to
provide other vaccines free for adults?
No, don't get me wrong.
My hepatitis B programs. You cannot say that is
okay.
Even free. Please, that statement is not in this case. You are working on what is their program for hepatitis B prevention. That's not
okay. What he's saying is that it's being given free, but he is insisting. Just come to Adama, you have it free at your disposal.
So it depends on the
state. In Abuja here, they gave it free. I saw adults that collected it.
All right. Okay. So it just depends on your state. Let's just leave that. Okay. So thank you very much for that clarification. Nurse Califat is asking.
Sorry, but I think there's my second part of the question.
Okay, go ahead.
Second part. Yeah, the second part of it is the births 4 weeks and 6 months is WHO immunization program. But there's a modified, I think Nigeria modified one said one at birth 1 month and 6 weeks. Is that what you are talking about?
Yes, sir. Yes.
Yeah,
they do it
1 month and 6 weeks.
No, they at the 0 dose, then the second month and the third month. That is within the 3 months, space. You have completed. You have taken the 3. I want to know if that because that is it happens in most of the primary health center.
Yes, it's supposed to be. That's a modified one. It's a modified that's recently, I think about 2 to 3 years ago. This advance, that is 0, then 4 weeks, then 6 weeks.
No, so I'm talking about adults. I'm talking about adults.
Advance is 0. Yes, at 0.
I'm making reference to for adult. Yes.
And that's what I'm saying, that at adult, you are taking 3 doses too. The 0 day, that is the day, the first one. Then the second one is going to be 4 weeks. That's a month.
Okay.
The third one will be 6 weeks.
Okay, 6 weeks.
6 weeks.
6 weeks. Okay, but I know the way your standard is 6 months. I mean, like 6 months.
Yes, that's 6 months. But if you are taking a booster dose now, which is a modified one, 0, 4 weeks, and 6 weeks.
Okay, sir. Okay. I just needed that clarification. Thank you so much.
Yes, sir.
No, sorry, sir. Is the 6 weeks, is it from the 0 dose or 6 weeks from the second dose?
It's the 6 weeks from the second dose.
Okay. All right. Thank you, sir.
I think that's wonderful.
Thank you so much, Dr. Dada, for the responses you've given to the questions and the clarifications. So Nurse Khalifat is asking, thank you for this. She's saying, thank you for this educative presentation. Please throw more light on the issue of a partner being positive and the other negative. How can further prevention be encouraged? And what is the risk level for the negative partner?
Yes, for concordant couples, for discordant couples, that's discordant means one is positive and one is negative. The negative couple now will take the vaccine.
What a minute. Please, has she come back?
Please, Dr. Kennedy.
You understand what I mean, ba? The negative couple, the negative, if the wife is positive, the husband will now take the vaccines, that 3 doses of vaccine. And if the husband is positive, the wife will take those 3 vaccines, as we said. That is what we just said. They call it discordant couples. So they will take, and once you take it, it has protected the husband or wife for life. You understand? And in the case of prayer for the baby, then we need that immunoglobulin at birth, especially if the patient did not go for antenatal to the extent that he commenced medical and the viral load is very high. So you need to take the immunoglobulin. The baby needs to take the immunoglobulin.
Okay, thank you so much for the response, sir. Okay, so someone is asking, Dr. Mohammed is asking, is treatment required for inactive carriers of HPV? There's people who are not showing.
Yes. No, no. We monitor those people. We monitor them by every 3 months LFT, then every 6 months viral load. However, once we also do what we call some blood tests to assess the level of fibrosis, because fibrosis is a structural things that we need to identify in liver too, which we normally regulated. We only go to blood assessment, but we don't assess the fibrosis of liver, because a fibrotic liver may be having normal level of viral load and LFT. So we have to calculate some level of fibrosis by using FibroScan or using a biomarkers from the blood to calculate. For example, we have FIB score. That is a fibrosis score that we use. And this involves the platelet, the ALT, the AST, and the square root of ALT to calculate a percentage, to calculate how much level of fibrosis in the liver, the hepatocyte. And if the level is corroborate with the standard measure that is done by the WHO into F1, F2, F3, F4, if you fall in between the F2 to F4, we have to start our management. So inactive carrier is not only by checking the viral load to be normal and the LFT to be normal, we need to assess the level of fibrosis of that patient too. And if it is normal, then we monitor every 2-3 months. Thank you.
All right, thank you so much, sir, for the response. And his second question is HPV curable? If yes, what is the line of treatment? If no, what is the way out if infected?
Yes, the term for a cure in HBV is not visible in our field. The reason is that, yes, once a patient opted for injectable care for hepatitis, which is using or uses of pegylated interferon, we have the 3 types. We have the 2A, 2B, and N3. The pegylated interferons are notable for giving us that quote cure in hepatitis B. However, many studies done shows that 55 to 62% of patients that maintain this interferon for 48 to 52 weeks were able to ascertain that level of cure. So what about the remaining percentage? And the problem is that the cost effective of that interferon is also very, very expensive. So what if you take it and you didn't fall into those cure state? And the study did not go a long way to know the effect, what may happen. Maybe probably there may be a resurgent or a relapse in the hepatitis. So that is why it is not really documented that hepatitis B is cured, but we manage. So that is why management of hepatitis B is divided into 4 aims. We call it aims, or 5 aims. Number 1 is to improve the quality of life of the patient. Number 2 is to normalize the liver function if it is deranged. Number 3 is to prevent the patient from developing hepatocellular carcinoma. Number 4 is to convert the E antigen seropositivity to seroconversion. And number 5 is to normalize the viral load to non-detectable. So it's aim, it is not cure. So that's why that functional cure that it is expected is found in pegylated interferon. But however, the percentage from the study done shows that 58 to 60% may have a functional cure. But in a long time, it is not done to know whether they may have a relapse. Thank you.
Thank you so much, sir. Thank you so much for that insightful response. Okay, so Dr. Osman Umar is asking, what is the dose for immunoglobulin? And then his second question is, for spillage in the ward with infected blood, what steps should be taken to address the situation? And 3, why can't some of these vaccines be provided under NHIS? Can we make some efforts and advocacy? I think that one has been addressed earlier. Okay, so go ahead, sir, Dr. Dada. He's asking.
The dosage for immunoglobulin, as I said, 0.06 ml per kg. 0.0 ml per kg. So we use it according to your kilogram. That's the dosage. Then once you are exposed to spillage in the ward, follow the IPPS component. Then contact, the IPPS component, wash thoroughly. When you wash thoroughly, you clean the surface, you cover it, then you contact the gastroenterology unit immediately where the drug will be prescribed for you to take. As I said, it is important to take it within 72 hours so that the efficacy is guaranteed rather than waiting for 7 days, which the efficacy is not really guaranteed. Then in terms of the making the drug free by NHI, yes, that is also a stakeholder meeting that need to be met with all the health stakeholders to discuss with the government how can these drugs and vaccines be available to NHI, just like what they did to the other antiviral agent like HIV and other. So I think it's a good question. We need to still also advocate for that to be given. Just like my colleagues that said this one is given free in Abuja, is a very good encouraging statement and words. We can extend it by raising it as an example to the extent that even some of these drugs, the tenofovir and the sofosbuvir, the direct-acting antiviral agent can also be available for NHIs to be because most of these they are drugs, they are expensive. Somebody, when we are resident, is only around 5,000, but it's around almost 40,000, 60,000 naira now for 30 days. So it's increasing, and you need to be included NHIs so that the money can be down and it will be more affordable, accessible for our patient to use. So it's a very good thing that we all need to come together to discuss this and how we can raise the advocacy to make sure that our patient can get it, access it through the NHIS. Thank you very much.
Thank you so much. Thank you so much, Dr. Dada. So quickly, I'm also going to share the feedback link in the chat box so we can get our feedbacks on how we can make this program better. I'll quickly read the next question from Dr. Peter. He said, thank you, sir. What are the treatment options for HCV infection? Treatment options.
Okay. The treatment option for HCV is once the patient is positive to anti-HCV, that is antibody to hepatitis B virus, we quickly do the RNA, that is hepatitis C RNA to know the viral load. You understand? Sometimes if the viral load is undetectable, that means the patient is exposed to the virus and the immunity has cleared it. But it has to be done twice. But if the viral load rises to any level above the undetectable level, then we have to start our drug with direct-acting antiviral agent. We have the punch, as I said, gone are the days that we had to go ahead to do the genotyping. Genotyping now is also very expensive. We cannot do because we have a vertical, alphabetical level of genotyping. We have A, B to almost about G. And we have to identify the genotype of this. I mean, our West Africa is around E, D and E that is available. We need to identify that genotype and get the drugs among the DAE that can tackle it. But nowadays, we have pangenotypic. The drug we are having now is pangenotypic means that drugs that can tackle any of the genotype that we have all over the world. So we just prescribe any of the available one that is affordable. We prescribe for a patient, and our patient will take it for 3 months. After 3 months, we do it for 12 weeks to check the viral load again. If it is still there, we continue. But we expect the viral load to be not detectable. That is when we stop. However, the anti-HCV will persist for life because the memory cell is already there to know that this patient has been exposed to hepatitis C virus in the past. Thank you.
Thank you for that detailed explanation. Thank you, Dr. Dada. So I think earlier, because Joseph was trying to ask a question before his, he was locked out from the call due to poor network connection. He was asking, so what is the position of an individual that took only 1 dose of the vaccine and is coming back after 10 years?
He's unvaccinated.
That's a long time.
He's unvaccinated.
So he has to start from the beginning. He has to start afresh.
Yes.
He has to start afresh. Okay, so there is a question here, sir. Okay, from Kadams. It says, sir, there is this different controversial opinion that the treatment, especially antivirus, should commence once the diagnosis confirms chronic HPV, especially. Why others insist certain diagnostic parameters like HPV profile, LFT, liver, ultrasound scan, viral load, and it's related. My question is, what's the appropriate timing to commence antiviral treatments?
Yes, she's right. According to guidelines, we have the American AGA, the American Gastroenterology Association. Then we have the ASLD guidelines too. What they said is that ideally, there are certain special people that once the hepatitis B virus is positive, they should start medication. And these people belong to under 40 years age in Africa and under 30 years in Asia, because of the endemicity and the oncogenic nature of hepatitis B. Most of them, they come with hepatitis B de novo. That is, it moves straight from the infection to cancer. That is hepatitis B de novo. So because of that,
Okay, thank you. Go ahead, sir.
But knowing fully well that once you start the drugs, you are going to stay it for life. And the cost implication of it, that is why sometimes we bend the rule, especially once you are around 45 or 40 years upward, you still bend the rule of saying, okay, do this test, let's check the viral load, let's do the profile. The profile will be able to know which one you belong to, whether you are E antigen negative or E antigen positive. Then let's check the LFT, is it the range? Let's do the fibro scan to see whether there is level of fibrosis before we start the medication. But the indication, there are some indication. Once you have less than 30 years in Asia, less than 40 in Africa, when you have a family history of cancer, hepatitis B, hepatocellular carcinoma in a family, you need to start the drugs. It's very, very important. So those are criteria that once the patient is detected and the patient has a family history of hepatocellular carcinoma, you need to start the drugs. So she's right. And we have to look into those considerations to prevent. Our aim, as I said, with those 5 aims I listed earlier, is to make sure that this patient live a beautiful quality life and spend the rest of his life happily. Thank you.
Thank you so much, Dr. Dada. I don't know if I'm sure I'm not the only one who is enjoying this section. And it looks like we might have to bring Dr. Dada again. We are really running short of time. I hope we've exhausted the questions. I put up the link that we should fill the feedback form. And also, I've posted another link for some of us who are joining for the first time. There are people who might be interested to become a member of NSIC Nigerian Society for Infection Control. The link up there is for you to share your details. So you could send an email to us, or you could also fill the form. For those of us who want us to share the recorded section, and also the slides with you, I want you to share your email. Use that link too. We're going to share the email with you. In NSIC, we're committed to fostering excellence in IPC through collaboration, education, and advocacy. And so that's why we have this monthly sections every usually last Thursday of the month, but because of the World Hepatitis Day, we decided to have our section today, and it's really been a very interesting one. Dr. Dada, we appreciate the time that you have shared with us, your expertise.
Thank you,
we really, really appreciate. Please do not put your email in the chat box. Use that link, because at the end of the session, I might not be able to get every one of it. But when you use that link that I shared, we can send the recorded section with you, and as well as the slides. And if you have further questions, you can get across to him through us. We'll share with him. Maybe we may have him again sometime in future. Yeah, Dr. Dada, that's the certificate of recognition. We recognize your invaluable contribution to this topic. I also share it with you via email. Thank you so much. I acknowledge that you had a very busy today. I could see when I called you, but you still made out the time to share this expertise with us. We really, really, really appreciate. And also thank you to your colleague, Dr. Lagoke. I really, really appreciate everything. Thank you. So please, we've come to the end of the section. This is almost please let's appreciate our speaker. Let's appreciate our speaker. Yes, let's appreciate him. He's really, really been a lot. Yes, this afternoon. I didn't even know when the time it's when we got to 3:30. Thank you so much, sir. I promise to share the recorded section with every one of us, including the slides. And if you want to become a member of NSIC, please use the link, share your details with us. We will reach out to you. You can send an email to us. We really appreciate everyone who took out the time to be here. Without you, this section wouldn't have been as interesting as it was today. Thank you for the contributions from Dr. Sempo and to everyone, Dr. Kennedy, everyone who made a comment, asked a question, and gave a contribution. For some of us, we might have to go back to ask questions in our facilities, ask the right questions why some of these vaccines are not available. Some of us, it might be available, but we do not know. And I also want to say it's free in Abuja. It's possible, very, very possible, very, very possible. If you're not getting something in your state, doesn't mean that someone else is not getting it. It's available. Let's ask the questions, advocacy that we hope that translates to actions. And like the team says, let's break it down. Those barriers to, eliminating hepatitis. Some people are not aware. Is it ignorance? Is it the stigma? Or is it a lack of accessibility to the vaccines, treatment, and testing? So we continue to, lend our voice as well as take actions. Thank you to everyone. And I look forward to having you again next month. We're going to have Dr. Lagoke and also we're going to have Nurse Olarewaju. She's going to do spotlight section with us, share facility experience on how IPC improvements, about the IPC improvements in her facility. So it promises to be a great one. I look forward to having every one of us last Thursday of next month. Thank you so much, and do have a great evening ahead. Thank you so much. Thank you, Dr.
Thank you very much. Thank you, everyone. Thank you very much. Thank you very much. Thank you.
Thank you.
All right, ma'am. Thank you.
All right.
Yes, ma'am.
Okay, bye.
Yes,
Thank you very much.
Thank
you.
you.
Dada.
Bye-bye. Thank you. Thank you. Thank you, everyone. I really appreciate.
Thank you,
Bye-bye.
Dr. Lagoke.
Yeah,
Thank you.
Thank you. All right. Yeah,
bye.
Thank you, sir. Thank you. Bye.
All right, bye.
Thank you, FMC.
Thank you, FMC. Yes, so thank you, FMC. They're doing a great job there. A lot is happening in the FMC, Epute Meta Lagos. We're so proud of you guys. Proud of your team. Thank you. We're proud of your IPC team. Thank you. Okay, so the link, in case you're using the link, I'm just going to stay like 2 more minutes so that people can use that link to share your email with us so you can get the recorded section and the slides. Bye.